I'm going to start my presentation on shock. I'm Firebank Sandoval for the two that I haven't met. Everyone else in the room. It's me. Hello. Thank you guys for coming. So let's get started. So for shock, I'm going to do a quick introduction to shock. I'm going to go over the pathophysiology and how it affects the different body systems. We're going to go over all the stages of shock, all four of them, and then all four types of shock, and then the ones that go kind of with the others. We're going to go over recognition and treatment of the shocks, shock with pediatrics, some case studies for you guys here at the end, and then a final conclusion. So let's start off. So what is shock? What is shock? Someone after what shock is. Hypoperfusion. You guys, what is shock? What have you learned about shock?
Shock, we would basically come from like decompensating, so you might go from, that's what I think of when I go
Yeah. So hyperperfusion, inadequate perfusion. Shock is defined as inadequate perfusion resulting from underlying conditions that compromise the delivery of oxygen and nutrients to the cells and the tissues, right? And so with that reduction of perfusion, that eventually causes, cellular damage, organ failure, and then eventually death. So inadequate perfusion, some key concepts. It's a mixed match between oxygen supply and demand. Your demand for oxygen is going to be greater than your supply that you have, and that's due to impaired cardiac output, vascular resistance, and blood volume. All right. And so then cellular hypoxia. This disrupts aerobic metabolism, forcing cells into anaerobic metabolism, which Spar was going over in his. The body starts producing less energy and leads to metabolic acidosis. And then with shock, it's a rapid progression. Shock can progress rapidly, moving from reversible stages to irreversible organ damage within minutes to hours if it's not properly managed. Cool. So, importance. Shock has a high mortality risk. Shock is the leading cause of death when you have critically ill patients and requires immediate medical attention. It's good to early recognize it. Identifying the signs and stage of shock allows us for rapid intervention, which is crucial for the patient's outcome. And then dynamic management, knowing and what types of shocks they are, and understanding the underlying cause, continuous monitoring, and adjustments in therapy allows us to be able to treat it better and treat them so they can go to the hospital, they can be stable, and they can get further care that they need there. So some pathophysiology of shock. Shock affects the heart, cardiovascular system. How do you guys think shock affects the heart?
Low blood volume.
Blood volume.
It makes it work harder until it just can't work as well.
Yeah. So your sympathetic nervous system kicks in. Your heart rate starts to go up. You have a decreased cardiac output, and you have some hypotension. The heart tries to pump harder and faster, and it can actually cause a strain and lead to heart failure. What about the lungs? What do you think the lungs? What happens with the lungs?
Like it's shunted away from parts of it, or tissue dies?
Tissue dies, okay. So when it comes to the lungs, inadequate oxygen exchange. When it comes to the respiratory system, your respiratory muscles, they can become fatigued due to the increased work of breathing, potentially into respiratory failure. So whenever you're going into shock, you're going to have an increased heart rate, and that's going to be causing the strain on the heart, and then you're going to have an increased work of breathing, which can also cause a strain on your lungs. And then the kidneys. What about the kidneys? Kidneys are also working harder. So if you notice, everything starts to work harder because the body, there's some kind of issue with the body. And so with the kidneys, there's a reduced blood flow that leads to damage of the kidneys, which eventually stops the kidneys from being able to filter waste, balance fluids, and electrolytes properly. So whenever shock happens, whenever the body goes into shock, there's a problem that needs to be solved, and the body tries to compensate for it. By doing that, it increases its heart rate, and it increases its blood flow, and by doing that, or the process of that, is caused by the kidneys, which is in the RAS system. Does anyone know what the RAS system is? Renin, angiotensin, aldosterone system. And that's how the kidneys start to feel like they're not getting enough blood flow to them, so then they start releasing renin. So they start releasing renin, and they do this whole process so they can get blood flow back to them, because they're not perfusing properly. So then, how do you think it affects the brain? Inadequate perfusion to the brain. Tissue death. So, decreased oxygen delivery to the brain. It leads to confusion, agitation, and then eventually loss of consciousness. They become semi-conscious, they'll eventually go unconscious. And then, what about the GI system and the liver? Kind of the same thing, right? Tissue death. They don't get enough blood flow, they're not getting enough oxygen, so tissue death is kind of going for everything. And so that can actually increase risk of gut bacteria entering the bloodstream, poor digestion, and liver dysfunction. And then with the blood, it actually causes clotting issues with the blood. Low oxygen, poor blood flow damages vessels, which makes clotting problems worse. And then the immune system, they can either have an overreaction or an underreacting response. Excessive inflammation damages tissues, or the body can't fight infections properly. All right, stages of shock. What are the 4 stages of shock? Start one by one. First, there's a level right before that. Initial stage, the initial stage. So then we go into the second stage, which is what? Compensated. And then the third stage? Decompensated. And then what's the final and fourth stage? Refractory, yep. So you have your initial stage, your early shock. Your compensated, your non-progressive stage. Decompensated, your progressive stage. And your irreversible refractory stage. So first is your initial stage. During this stage, it's mild hypoperfusion, and this is when the body shifts to anaerobic metabolism from aerobic metabolism. This is when the body starts to figure out that there's something going on, that there's something going wrong with it, and it needs to try and figure out how to fix it. And so during this stage, the signs, there's actually really no symptoms during this stage, other than maybe an increase of heart rate, kind of just the body noticing that there's a decrease of perfusion, and maybe just a little bit, it will increase the respiratory rate as well, kind of just help you start breathing a lot faster as well. And then the importance is just early recognition of this, that there's an issue, kind of like with people at their own homes, like figuring out that there's something going on, they're feeling sick, they're not feeling too well, they're feeling a little bit weaker. Whenever you recognize that a lot earlier, you can solve the problem, to which prevents you from going into the later stages of shock. Compensated shock, the non-progressive stage. So this is when the body starts to compensate for what's going on. Now the body knows that there's an issue that needs to be solved, so now it's trying to fix that issue on its own. By doing this, it's going to start the RAS, it's going to start the sympathetic nervous system, it's going to kick in, it's going to increase the heart rate, increase the blood flow, because it's not getting enough perfusion. Signs of this is going to be an increased heart rate, cool pale skin, normal or kind of slightly lower blood pressure, and then fast breathing. And the importance of this is the warning stage. This is the body kind of letting you know that, hey, something's going on with me, something's not right, something needs to be fixed, or things are going to get a lot worse. Then third, this is going to be the decompensated stage, your progressive stage. During this is the failure of compensation. This is when your body tried to fix that issue, tried to fix that problem. It knows that there's something going on, but it wasn't able to fix that issue on its own. This worsens the oxygen shortage that it already has. And the signs of it is going to be hypotension, weak pulse, confusion. They're going to be going in and out of consciousness. They're going to have rapid, shallow breathing and reduced urine output. And the importance of this is the point where the body becomes overwhelmed. This is where the body is not able to compensate anymore at all. It's not able to work and it's not able to fix the issue like it could have in the compensated stage. And this is when it needs our interventions to fix the issue. And then final, your irreversible refractory stage. So during this is your severe organ failure and your death. Your irreversible stage, once you get here, it's kind of over. Your body tried compensating. It kind of tried getting that help, asking for that help, and now it no longer can get that help. Signs of this, very low blood pressure, irregular heart rhythms, and unresponsiveness. The importance of this is irreversible. As it says, irreversible. There's no reversing this. It's leading ultimately to death. This is going to end up being the code. And in all these stages of shock, rapid transport, rapid treatment, as fast as you can, just identifying the issue and trying to figure out what's going on so you can fix it and prevent them from going to the later stages of shock. All right, types of shocks. What are the 4 types of shock? Four main types of shock. Hypovolemic shock, cardiogenic shock, obstructive shock, and distributive shock. Obstructive, distributive, yep, cool. So those are all the types of shock. So let's go over them. So hypovolemic shock. What causes hypovolemic shock? Burns, hypovolemia, dehydration, bleeding, hemorrhaging, trauma. So this is where there's reduced blood volume, and during hypovolemic shock, the body kind of does the same thing of kind of trying to fix the issue, trying to increase the heart rate, same RAS system. And the complications with it is it causes organ failure, and it makes shock progress later into those later stages. Cardiogenic shock. What are the causes of cardiogenic shock? Heart attacks, CHF, heart attack, CHF, cardiomyopathy, severe arrhythmias. What kind of arrhythmias are there? What kind of blocks are there? What kind of blocks can send us into cardiogenic shock? Third degree blocks. What kind of arrhythmias can send us into cardiogenic shock? VTAC, VFib. Well, VFib, you're dead. So. Cool. Impaired heart function, poor perfusion. Cardiogenic shock, you're essentially just think. So when you think hypovolemic shock, think of volume. Hypovolemia. The body is having a volume issue. When you think of cardiogenic shock, think about the body is having a heart issue. There's something going on with the heart. There's poor perfusion to the heart. Complications of this, again, organ failure, worsening shock conditions, and worsening heart conditions. Now, distributive shock. There's 3 types of shocks that go into distributive shock. What are they? Anaphylaxis, neurogenic, and then septic shock. What's anaphylactic shock? Allergic reaction. What's neurogenic shock? Spinal cord injury. Yep. And then what is septic shock? Systemic infection. And so the key difference or similarity between all these is it causes widespread vasodilation in all those different types of shocks. And then complications, organ dysfunction, respiratory issues, cardiovascular issues, systemic infections, as you guys stated. Now, obstructive shock. What kind of things would you think about when you think obstructive shock? Tension pneumo. Cardiac tamponade. Just two more, a couple more things I can.
Yeah.
Oh, PE.
PEs. What is a PE? You guys.
The pulmonary embolism.
Okay, cool. And then what's the final one? Aortic dissection. And so this is impaired blood flow. Whenever you think of obstructive shock, think about there's a blockage, there's something that's stopping blood flow, and it's causing reduced cardiac output. Again, complications for all these, organ failure, progressing into worsening shock conditions. All right, recognition and treatment for shock. What position is this?
Trendelenburg.
Yeah, Trendelenburg. So first, how do we recognize and how do we treat hypovolemic shock? So, yeah, giving fluids. So first, let's go over the recognition of hypovolemic shock. What kind of signs and symptoms are they going to be having? They're going to have hypotension, they're going to be tachycardic, they're going to be tachypnea, I can't pronounce that. They're going to have it's a fast breathing. They're going to have pale, cool, clammy skin, weak or thready pulse, altered mental status, decreased urine output, dry mouth, weakness, dizziness, fainting, nausea, and vomiting. So how do we treat it? So we treat it with fluid resuscitation. If it's hemorrhagic, then we're controlling the hemorrhaging. If it's due to dehydration, we're managing the dehydration with the fluid resuscitation. We're going to do vasopressors if their blood pressure is getting too low and it's not reacting to fluid resuscitation. If it's from dehydration of nausea and vomiting, antiemetics, Zofran, giving them Zofran, and then just oxygen, and then of course Trendelenburg. Cardiogenic shock. signs and symptoms of cardiogenic shock. They're all pretty much almost the same. Hypotension, tachycardia, they're going to be tip. They're going to have fast breathing, pale, cool, clammy skin, weak or thready pulse. They're going to have some kind of edema, JVD, muffled heart sounds, dyspnea, chest pain, altered mental status, and decreased urine output. The edema from CHF, it's going to be peripheral edema. And then the treatment for cardiogenic shock. So fluid management, oxygen, we're going to treat arrhythmias and blocks, and vasopressors. So for the medics, how do we treat arrhythmias and how do we treat our blocks? What are the different ways that we can treat them?
Pacing.
So we can pace when we have our blocks that are bradycardic, and then when we have our rhythms that are too fast, then we're going to synchronize cardiovert. And then if it's unstable, we're getting to those, but if it's stable but symptomatic, then we're going to be using our meds that we have. Our meds, diltiazem, adenosine, amiodarone later down the line after cardioverting and all that. Oh, shoot. All right, distributive shock. So first, septic. Septic shock, they're going to be warm, flush skin because of vasodilation instead of vasoconstriction. They're going to have a fever, they're going to be they'll either have a fever or they'll be oh my goodness. They either have a fever or have hypothermia. They're going to be tachycardic, hypertension, altered mental status, and then signs of infection. Look for signs of infection whenever you're looking at the patients that are going to be in sepsis. If they had a recent surgery, they have some stitches, they're going to have some redness, some pain there, pain to the touch, hot to the touch, white or yellow pus coming out of them. And then to treat sepsis, fluid resuscitation, pressors if the fluid resuscitation doesn't work, oxygen, and then supportive care for any pain that they may have. So anaphylaxis. What are some things we're going to see with anaphylaxis? Urticardia.
Facial swelling.
Facial swelling.
Swelling of the airway.
Yeah, swelling of the airway. What kind of lung sounds are we going to hear? Wheezing. What else? Stridor. All right, cool. They're going to be tachycardic, hypotensive, and there's a chance that they may have some abdominal pain. How do we treat anaphylaxis? Epi. What kind of epi? Epi 1 to 1,000. And then we're going to treat and then we're going to do Benadryl, Dex, a dual neb, some fluid resuscitation, and then oxygen. So I missed anything there. Okay. And then neurogenic shock, warm, dry. There's warm, dry skin. They're going to be bradycardic, hypotensive, again, altered mental status. They're going to have decreased reflexes. For neuroshock, we're going to do fluid resuscitation, vasopressors, oxygen, supportive care for the pain, and then management of the spinal cord, C-collar, or the C-spine, or the backbone. Cool, and then finally, obstructive shock. Signs and symptoms are going to be hypotension, tachycardia, tachypnea, pale, cool, clammy skin, and then for a PE, what is the giveaway tell for a PE?
Oxygen sat not corrected by supplemental oxygen.
Oxygen sat not corrected by supplemental oxygen, and then what else? Pinpoint chest pain. And then they're going to have some cyanosis, and then just sudden shortness of breath. Cardiac tamponade, JVD, muffled heart sounds. Pulseless paradoxis. What is pulseless paradoxis?
Your EKG, tall and small.
And then tension pneumo. What is our dead giveaway for tension pneumos? Absent lung sound, or decreased lung sounds on one side. And then you can also have some tracheal deviation. You'll also have severe dyspnea. And then aortic dissection. What are we looking for when we're suspecting someone has an aortic dissection? Mass. They're going to be complaining of what? Rib tearing pain in their back or their kind of chest area and stomach. Narrowing pulse pressures. Unequal pulse pressures, yeah, narrowing pulse pressures. And then pulse defects. Treatment, oxygen, supportive care, Trendelenburg, fluid management, vasopressors, and then for tension pneumo for medics, needle decompression. All right, shock with pediatrics. So pediatrics often compensate for shock more effectively than adults. They can actually maintain a normal blood pressure and heart rate even in the earlier stages, and they actually won't show anything until the very late stages of shock. And they won't even show hypotension until even the decompensated stage, or the irreversible stage. And so they do present just a tiny bit differently, especially whenever you're looking at pediatrics. the pediatric triangles, whenever you're assessing their ultramental status, for them it's going to be irritability, lethargy, decreased responsiveness. Their skin's going to be kind of the same with pallor, cold, clammy, and sometimes sepsis, they're going to be warm and flushed skin. The treatment difference is our fluid resuscitation. They require careful calculations of fluid volumes based on weight and age. Rapid administration of fluids is often necessary, but overloading should be avoided. And then when it comes to medications, they must be adjusted for the body weight and the developmental stages. And then pediatric patients are more sensitive to dosages. What are some ways that we can figure out how to give the right amount of fluids and the right amount of our medications for pediatric patients? And Tevi. So what is our our dose for fluids for a pediatric patient? It's 20 mLs per kilogram. And it says that in hand Tevi too. So you can go into hand Tevi and go check, and it's under medications, not under drips. And then you can click on fluids. It's going to be normal saline, and it'll tell you the right amount. And what kind of equipment can we use to kind of help titrate that amount that we need? Uretrol. All right, now I got some case studies for you guys. I have a 68-year-old male with a history of hypertension and diabetes. Presents with abrupt onset of diffuse abdominal pain with nausea and profuse vomiting. The physical assessment, the patient is afebrile with pale, cool, clammy skin. His vitals are as follow. Blood pressure of 86/58, heart rate of 110, standing at 94%, a BGL of 180, and a totally normal sinus rhythm with peak T waves. What type of shock, what stage of shock, and what is our treatment for this patient?
What did you say, John?
If you got it, raise your hand. Hypovolemic,
And decompensating?
decompensated, and then how do we treat it?
Fluid?
Fluid, yeah. Huh?
Drive really fast.
Track really fast, yeah. Trenbolone.
Yes.
Decompensated, hypovolemic, fluid resuscitation, and then pressor is brief, the fluid resuscitation does not work. All right. 55-year-old male at his own home presents with weakness, nausea, dizziness, and chest discomfort. Patient states it's a dull pain and stays in his chest. Pain is 4 out of 10, and nothing makes it better. Physical assessment shows pale, cool, clammy skin, and he is very diaphoretic. His vitals are as follow. A blood pressure of 89/60, heart rate of 50, standing at 90%, BGL of 128, temp of 98.3, and a 3 lead is showing a 3rd-degree block. What's our stage? What's the type of shock, and how do we treat this?
Cardiogenic
Cardiogenic,
and decompensated.
decompensated, and then how do we treat this? Pacing. Pacing, and then rapid transport to the hospital for every single one of these patients. So decompensated, cardiogenic, fluid resuscitation, oxygen, vasopressors, and pacing. 81-year-old female, resident of a nursing home, presents with altered mental status. Patient states that she has a pain on urination, and nursing home staff stated an unusual smell in her room. Physical assessment, pink, warm, and dry. Vitals are as follow. Blood pressure of 94/68, heart rate of 104, standing at 96 on 2 liters, temp of 102.9, and a BGL of 220. Compensated, septic, and then how do we treat? Fluids. Distributive, sepsis, fluid, and then just keep her on the oxygen that she's on. 41-year-old male presents after MVC complaining of decreased sensation below his waist. Physical assessment shows pink dry skin with warm extremities. Vitals as follow. Blood pressure of 82/48. Heart rate of 52, standing at 92%. A BGL of 120 and a temp of 99. Decompensated, neurogenic, and how are we treating it? Fluid and pressures, and what else? C-spine percussions, yep.
It's bad for you anyway.
All right. 6-year-old female was dining at a restaurant with her family, where shortly after eating the first few bites of her meal, became anxious, diaphoretic, began wheezing, and noted a diffuse rash, nausea, and sensation of her throat closing. Vitals as follow. Blood pressure of 92/70, heart rate of 140, standing at 88%, a BGL of 102, and a temp of 98.3. what kind of shock, what stage of shock, and then for hand heavy, go into hand heavy and figure out what our dosage is for this patient is.
How heavy is your hand? His hand's pretty heavy.
Reflexes,
That's a heavy hand.
compensates.
Pediatric.
Yeah, let me just run.
This is gonna change things.
Our dose for epi, or,
Dose for the full treatment for
alright, we want 0.22 mLs,
0.22 mLs of epi,
which is 0.22 mgs.
0.22 mg.
So epi is gonna work.
Okay. Benadryl,
Oh, shit.
0.4 mils of
Give it.
Benadryl.
0.4 mLs of Benadryl. Our Joliet is going to be
Give it.
Given.
As is.
And it gives 3 mils of albuterol
He's gonna get that.
2.5 milliliters of ipratropium.
Yep. Dex,
1 ml?
Yeah,
1 ml.
And then oxygen.
and then oxygen. Cool. And then finally, 26-year-old male was in a single-person dirt bike accident. Patient has sensation in all of his extremities and bruising is present in his chest region. The patient's main complaint is difficulty breathing. Vitals of a blood pressure of 100/72, heart rate of 130, static at 90%, BGL of 98, and a temp of 98.3. Absent lung sounds on his right side and clear on the left. Obstructive shock. What stage are we at?
Compensated.
Compensated. And then what's our treatment? Chest start. Fluid resuscitation, fetal decomp, and then hospital. So, in conclusion, shock is a critical condition that requires prompt recognition, rapid assessment, and timely interventions to prevent severe complications and improve patient outcomes. Understanding the different types and their unique pathologies is crucial for the effective management of shock. By recognizing early signs and initiating appropriate treatment promptly, we can significantly impact patients' outcomes in both pediatric and adult populations. Understanding shock and its management equips us with the knowledge to act decisively in emergency situations, ultimately saving lives.
Oh, yeah.
Good job, Sam.
Got it?